me a little bit talk about skeletal changes in common skeletal dysplasias. My talk is very simple, basic, and may sound a little bit outdated. However, radiological diagnosis is still essential to ascertain at least molecular results. So I have to tell you that I'm not so fluent in English, so please be patient for my accent for a while. Needless to say, the overall pattern is important to make a diagnosis. Here is an example. You can see two neonates with facial abnormalities. In both, you can see rhizomelic shortening of the limbs, shortening of the proximal segment of the limbs, particularly of humerus. You also can see punctate calcifications like that, in other words, stippled epiphyses. But pattern is different. On your left, you can see severely epiphyseal stippling. On the other hand, on the right, you can see mildly spinal and severely mildly spinal and mildly epiphyseal and severely spinal stippling on your right. So on your left, you can see multiple corner cleft like that, and patellar stippling. And on your right, you can see severe plateau spondyly and tibial shortening like that. So what do you think about the diagnosis? Left is, does someone answer the question? Left is RCDP, rhizomelic chondrodysplasia punctata, due to abnormal perioxysome. Right is CDP, tibial metacarpal type, due to abnormal vitamin K metabolism. To recognize the overall pattern, we should evaluate which bones and what part of bones are affected and how they are affected. We should evaluate bone mineralization, pattern of bone deformity, shape of the diaphysis, metaphysis, epiphysis, spine, and iliac bones, and if relevant, the underlying pathogenic mechanism may be interesting. Here are three common bone dysplasias: achondroplasia, and spondyloepiphyseal dysplasia congenita, SEDC, and osteogenesis imperfecta, OI. Diagnosis of OI, generally speaking, is straightforward because of bone fragility associated with multiple fractures, bowing of the limbs. However, there may be some pitfalls. Here you can see classical thick bone type of OI. You can see defective skull ossification, beaded ribs, vertebral compression, and crumpled thick long bones due to multiple fractures. On your right, you can see different type of lethal OI. Again, you can see defective skull ossification, beaded ribs, but vertebral compression doesn't exist. Long bones crumpled, but slender, not thick. Also, you can see some sclerosis of long bones. So what do you think about the diagnosis for this case? This is a special type OI, termed OI type 2C, as a result of C propeptide mutation in type 1 collagen gene. Here's a mild OI. You can see prenatal bowing, slender, long bones, metaphyseal osteopenia like that, and multiple Womian bones like that. What about this one? Again, you can see prenatal bowing of the femora and You can see scapular hypoplasia like that. Scapular blade is present, but we are not able to see scapular wing in this case. And you can see very sharp spur here termed borderless spur. So diagnosis is campomeric dysplasia. Again, mild OI. You can see obtuse angulation of the femur, slender long bones, and metaphyseal osteopenia. What about this case? As compared with OI, you can see sharp angulation of the femur, normal diaphyseal diameter, and normal metaphyseal mineralization. And again, you can see borderless spur. What about the diagnosis? Thank you. This is a benign type prenatal hypophosphatasia. As you know, achondroplasia is caused by gain of function of FGFR3 signaling, resulting in reduced endochondral bone growth. Radiological consequences are metaphyseal cupping, metaphyseal spur, trident acetabulum, mild platyspondyly, and narrow spinal canal. Here you can see metaphyseal cupping and metaphyseal spur like that. That is because impaired endochondral growth is most severely affected in the central zone of the growth plate. Endochondral growth plate is most severely compromised in the oldest chondrocyte of the central zone of growth plate. On the other hand, juxtaphyseal intramembranous bone formation is normal or maybe mildly increased. So these mechanisms causes metaphyseal cupping and metaphyseal spur like that. What about a spondylar change of achondroplasia? Growth plate equivalent is the spine, endoplate, and neurocentral synchondrosis. Endoplate governs growth of vertebral body. On the other hand, neurocentral synchondrosis governs elongation of neural arch. Defective growth of endoplate causes mild platyspondyly. As compared with a normal infant, you can see a little bit flat vertebral bodies and very short neural arch. Defective growth of neurocentral synchondrosis causes very short posterior neural arch like that. What about the spine in achondroplastic child? Again, you can see very short neural arch as compared with a normal child, and a little bit flat vertebral bodies. And also you can see posterior scalloping of the vertebral bodies like that. That is caused by pressure erosion of pulsatile cerebrospinal fluid in the very narrow spinal canal. In normal child, interpedicular distance of the lumbar spine increased caudally. However, achondroplastic child shows inferior narrowing of the interpedicular distance. That is because impaired growth of the neural arch is most severe in lower lumbar spine. On MRI, you can see very narrow spinal canal, posterior scalloping of the vertebral body like that, and very severe spinal canal stenosis in the lower lumbar spine. Impaired growth of the skull base causes stenosis of the foramen magnum, sometimes associated with myelopathy like that. Clinically, this complication causes infantile apnea, sudden quadriplegia, and even sudden death, particularly at younger children. Fortunately, this complication becomes less frequent after 2 years of age. What about the iliac change of achondroplasia? Growth plate equivalent of the iliac bone are iliac crest cartilage and torriradiate cartilage. Iliac crest cartilage governs cranial growth of the ilia, while torriradiate cartilage governs caudal growth of ilia. Defect of iliac crest causes short squared iliac wing. As compared with a normal child, you can see short and narrow iliac wing. Defective growth of the radiate cartilage causes short greater sciatic notch like that. This is normal greater sciatic notch. And horizontal acetabulum like that, and trident acetabulum. What is a trident acetabulum? As compared with a normal infant, you can see first spur here, second spur here, little bit spur here, and the first concavity here, second concavity here. This configuration is termed trident acetabulum. This is equivalent to metaphyseal cupping and metaphyseal spur of the long bones. As you know, FGFR3-related bone dysplasia include most severe thanatophoric dysplasia, prototype achondroplasia, and milder hypochondroplasia. In all entities, you can see common skeletal changes such as iliac hypoplasia, proximal femoral radiolucency like that, and metaphyseal cupping. These disorders show less phenotypic overlap, in other words, discrete phenotypes, because of common mutations in each disorder. Intermediate phenotype is very rare. Trident acetabulum can be seen in skeletal ciliopathies. Here are June syndrome and more severe short-lived polydactyly dysplasia. In both, you can see 1 to 3 spur trident acetabulum. Skeletal ciliopathies are caused by defect of genes related to ciliogenesis. Endochondral growth failure occurs in selective bones, such as ribs, pelvis, and short tubular bones, and to a lesser extent in long bones. Radiological consequences include short ribs, trident acetabulum, brachydactyly with cone-shaped epiphyses. Long bones are variably affected. Interestingly, we can see premature epiphyseal ossification of the proximal humerus and proximal femur. Here is a child with June syndrome. You can see severe brachydactyly with cone-shaped epiphyses like that. Epiphysis looks like cone. Also, you can see thoracic hypoplasia with short ribs and mild iliac hypoplasia and mild cupping of the distal femur. Skeletal ciliopathy shows trident acetabulum as a neonate, but trident acetabulum evolved into mild iliac hypoplasia with age like that. Here are June, Erispan-Kuribert dysplasia, and short-lived polydactyly syndrome. You can see narrow thorax, trident acetabulum, brachydactyly with or without polydactyly in all disorders. Also, you can see premature ossification, epiphyseal ossification of the proximal humerus and proximal femur. This is a very interesting, very distinctive findings for skeletal ciliopathies. This is a question for you, case A and case B. First question is, both shows trident acetabulum, yes or no? Yes, thank you. Thoracic hypoplasia is more severe in case B. Of course, yes. But spondyly is more severe in case A. Yes. All answer is yes. Short limbs are more severe in case A. Yes. So diagnosis A is, thank you, thanatophoric. B is short-lived polydactyly dysplasia. SEDC, spondyloepiphyseal dysplasia congenita, is the most common phenotype of type 2 collagen-related bone dysplasias. Hallmark is delayed ossification of just truncal bones. Radiological consequences include delayed pubic ossification, pear-shaped vertebral bodies, and delayed ossification of proximal femoral epiphyses. Odontoid hypoplasia associated with C1-C2 instability is a common syndromic component of this disorder. Despite very short, long bones, short tubular bones is normal in length. Here is a case with SEDC. You can see delayed ossification of the pubic bones as a neonate, and then double ossification of the pubic bones at age 10 months as a consequence of delayed pubic ossification. Also, you can see pear-shaped vertebral bodies. As compared with the normal infant and child, you can see pear-shaped vertebral bodies in SEDC. That is because, as a fetal period, ventral ossification of vertebral bodies precedes that of dorsal ossification. So this finding persists even after birth due to delayed vertebral ossification in SEDC. Here are two cases with SEDC. You can see pear-shaped vertebral bodies, delayed ossification of the proximal femoral epiphysis, odontoid hypoplasia with C1, C2 instability, and normal short tubular bones. Type 2 collagen-related bone dysplasia include most severe achondrogenesis type 2, intermediate hypochondrogenesis, and prototype SEDC. You can see delayed ossification of vertebral bodies, pubic bones, metaphyses, or proximal long bones in all disorders. These disorders show continuous phenotypic gradient because mutations are dispersed throughout the gene. There are many intermediate phenotypes. We can see delayed pubic ossification in cradle-cranial dysplasia. Ranks defect in CCD causes delayed cartilage maturation, resulting in delayed pubic ossification like that. And also you can see large epiphyses or mega epiphyses as a hip. That is because delayed cartilage maturation causes central position of the growth plate, as shown in this cartoon. Ranks 2 defect impairs intramembranous bone formation as well. So you can see wide fontanelles, multiple Womian bones, and clavicular hypoplasia, variable in severity. Stickler and Nist dysplasias are another type 2 collagen-related bone dysplasias. Hallmark is broadening of growth plate probably due to swollen cartilage matrix. Radiological consequences include wide metaphyses that may manifest dumbbell deformity of the long bones, broad ilia, broad vertebral bodies varying in severities. We may see a coronal cleft in these disorders. Coronal cleft, how does it come? That is because ventral and dorsal segments of the vertebral body are separately ossified like that. The coronal clefts are due to delayed fusion of the both segments. We can see coronal clefts in various disorders in type 2 collagen abnormalities like that, in Nist dysplasia in like that. And also we can see multiple coronal clefts, rhizomeric type, chondrodysplasia punctata, and even intrauterine growth retardation because the coronal cleft is a result of delayed maturation of vertebral bodies. Dumbbell deformity, we can see dumbbell deformity in various disorders. Dumbbell in Nist, dumbbell type 11 collagen abnormalities, otospondylon mega epiphyseal dysplasia, and metatropic dysplasia due to TRPV4 mutation. Metatropic dysplasia is TRPV4 related skeletal dysplasia. Hallmark is broadening of the growth plate and its equivalent probably due to hyperchondrogenesis as shown in this cartoon. Radiological consequences include severe dumbbell deformity, striking broad ilia termed Harvard ilia, severe protispondy with broad vertebral bodies. Progressive kyphoscoliosis is clinical hallmark of this disorder. What about the spondylar change of metatropic dysplasia? You can see very broad, flat vertebral bodies in metatropic dysplasia as compared with normal infant. As compared with a normal child, you can see so-called overface of pedicles. You can see pedicles is overfaced with the lateral edge of the vertebral bodies on the frontal view due to very broad vertebral bodies. What about the iliac change of metatropic dysplasia? That is termed Harvard pelvis. You can see very broad iliac wing, broad acetabulum. Also, you can see concavity here. So iliac bones dumbbell like that. TRPV4 associated bone dysplasia comprise continuous phenotypic gradient in severe metatropic dysplasia due to dispersed mutations, and discrete phenotype, mild metatropic dysplasia, and spondylometaphyseal dysplasia type Kozlowski due to presence of common mutations in these disorders. Dumbbell deformity and coronal crest can be seen in PARCAM abnormalities due to heparin sulfate proteoglycan type 2 mutations, severe dissegmental dysplasia, and milder Schwarz-Jampel dysplasia. In both, you can see dumbbell deformity, bowing of long bones, and multiple coronal clefts. In dissegmental dysplasia, coronal cleft is very severe, and you can see variable in size vertebral bodies. That is why this disorder is termed dissegmental, multisegmental dysplasia. In Schwarz-Jampel dysplasia, you can see hypoplastic ossification of C2. Personally, I think this finding is important to make a diagnosis of this entity. This is a second question. Question A, both shows dumbbell deformity. Of course, yes. Question B, lower interpedicular distance narrowing of the lumbar spine is seen in type A. Yes. But spondyl is more severe in case A. Yes. Coronal crest can be seen only in type, case B. Yes. You can see cleft here in this case, but this is very wide, neurocentral synchondrosis, but not coronal crest. So diagnoses are metatropic and niche dysplasia. Metaphyseal dysplasia is caused by disorganized ossification of the growth plate. Here are three cases: hypostotasia, metaphyseal dysplasia type Schmidt, metaphyseal dysplasia type Janssen. In hypostotasia, defective matrix calcification causes persistent cartilage metaphysis and irregular metaphysis. In Schmidt, abnormal type 10 collagen at chondro-osseous junction causes disorganized metaphyseal ossification and irregular metaphysis. In Janssen, increased PTH-RP, PTH receptor type 1 signaling, increased signaling causes very severely delayed cartilage maturation. So you can see wide growth plate and irregular metaphysis and large epiphysis, mega epiphysis, like CCD, cleidocranial dysplasia, due to very delayed maturation of cartilage. Here are three cases of metaphyseal dysplasia: Schmidt, cartilage ear hypoplasia, Shibak1 diamond syndrome. You can see different pattern in different types. In Schmidt, you can see both knee and hips are almost equally affected. In cartilage hair hypoplasia, you can see severely affected of the knee, but less severely affected hip. In Shibak1 syndrome, hip is more severely affected as compared with the knee. Epiphyseal dysplasia is caused by disorganized epiphyseal ossification due to abnormal epiphyseal matrix and may be late manifestation of chondrodysplasia punctata. Here you can see irregular small epiphyses in comp-related disorder. And this is CDP. You can see epiphyseal dysplasia, small irregular epiphyses in the distal femur, but proximal tibia looks normal. As a neonate, this case shows severe punctate calcifications, but the consequence is variable from place to place. In this case, you can see epiphyseal dysplasia only in the distal femur, but not in the proximal tibia. Here are two cases, comp-related disorders, mild MED, multiple epiphyseal dysplasia, and severe pseudoachondroplasia. Epiphyseal changes may be similar to each other, but mild MED shows almost normal lateral bodies. On the other hand, severe pseudoachondroplasia shows irregular lateral bodies associated with platyspondyly and anterior projection, so-called anterior tongue of the vertebral body. Here are three cases, epiphyseal dysplasia. Again, you can see different pattern in different types. In comp-related MED, you can see very small and little bit round epiphyses. In Matrix 3-related MED, you can see small flat epiphyses. In type 11 collagen-related MED, you can see severe epiphyseal dysplasia of the knee, but hip is almost normal. This is the last quiz. This case shows craniosynostosis with kappa-beaten appearance of the skull, narrow thorax with wide costal, anterior costal end, coarse trabecular pattern of the bone, metaphyseal irregularity like that, and bowing of the radius. And what is this? What do you think about this one? You can see horizontal radiolucency here. This is a so-called pseudofracture, a mineralized osteoid. So diagnosis is, please. Thank you. Child type hypophosphatasia. Of course, diagnosis is easy based on laboratory findings, but radiological diagnosis may be difficult. At the meeting of Albi, Valerie showed case similar to that one. Thank you for your listening.
Thank you very much, again. It was beautiful. X-rays were really wonderful. And it was quite interactive. Any questions? To still have some undiagnosed cases, some cases with really unknown diagnosis, you don't know when you are looking at X-rays. Not a lot.
Did you ever see Pierre Bitoun from Paris? Wonderful show. We loved it. Did you ever see spondyloepiphyseal dysplasia with glaucoma?
Of course, achondroplasia and osteogenesis are more. Yeah, one of the common skeletal dysplasia. Yes, eye problem and the hearing impairment is common in SADC.
If there is no more questions, it was beautiful. Thank you very much, Ken.